Hi, hello, namaste. Welcome to iMusics. Recently, I saw in my clinic one patient who was using this Ozempic. Now, Ozempic, Munjaro are being commonly used in diabetes and weight loss and many other conditions. All of them came for an off-the opinion as they were sent by their general physicians. As ophthalmologists, it is important for us to know about these drugs and what are the implications to know because we'll have to look at them and probably monitor them as they use this drug. This is an interesting article which I came across while I was doing research on what we have to know about these GLP1 receptor agonists. So, in this talk, we will look at the mechanism of ocular effect of these drugs and the disease impact map, the what are their effect on specific diseases like diabetic retinopathy, age-related macular degenerations, the NAION, IIH and glaucoma, dry eye disease, and we'll do a drug by drug comparison and perioperative safety, and also what are the key takeaways and limitations. So, how are the GLP1 receptor agonists affecting the eye? Retina and optic nerve are direct extensions of the CNS, where GLP1 receptors are widely expressed. These GLP1 receptor agonist drugs have anti inflammatory properties where they increase the IL-10, decrease the IL-1, interleukin 6, and TNF alpha. They also decrease the oxidative stress. They have neuroprotective action where they are decreasing the stress on the endoplasmic reticulum. They improve the astrocyte metabolic function. They increase the nerve growth factor and they increase the neurogenesis. They also have some systemic effects like they increase the satiety, decrease the hunger, decrease the gastric emptying, decrease the hemoglobin A1C and body weight, and also increase endogenous insulin release. Retinal ganglion cells and RPE are especially vulnerable to glucose stress, oxidative damage, and inflammation, the same pathways which GLP-1 signaling modulates. Now, if we look at different diseases, this is in short what are all the diseases. So it has been shown to be protective for few diseases, and we don't know about the role of it in some, and it is found to be there's a debated increased risk of disease of certain ocular diseases. Like in diseases of glaucoma, idiopathic intracranial hypertension, dry eye disease, and non-exudative ARMD, it is found to be likely protective. Whereas in exudative or the wet ARMD and the diabetic retinopathy, it is having a mixed sort of a review. Whereas in NAION, there is a debated risk that there because some studies are showing almost 2 to 4 times the risk increases with the use of these drugs. Now, if you look at single diseases, diabetic retinopathy, there are conflicting trial results. Hazard ratios for diabetic retinopathy versus placebo in major trials have shown that only sustained 6, which is a trial on semaglutide, was statistically significant. The hazard ratio in this was close to 1.76 with a 95% confidence interval of 1.11 to 2.78. But there are certain limitations like PDR was not excluded and baseline dilated fundus examinations weren't required. Early worsening with rapid glycemic control is a phenomenon which was also seen with insulin. So that could also be one risk factor. And these are all retrospective EHR studies where the material was taken from the electronic records and they were surveyed. Ongoing focus trial, which will report into 2027, will probably give you a better idea as to how the diabetic retinopathy will be affected by these drugs. Coming to the age-related macular degeneration, now here there is a genuine split. In non-exudative ARMD, it is found to be protective, where the risk of ARMD is decreasing as proven by certain studies. But in wet AMD, there are certain studies which are showing the increased conversion of non-exudative to exudative. So again, we are in a crux whether we have to use it, whether we have to consider it to be protective or non-protective. Now, why do these studies disagree? Because there is inconsistent propensity score matching for BMI, HbA1c, and smoking status across studies, and there is a reliance on ICD code diagnosis rather than confirmed imaging or manual chart review. There are different comparator groups like metformin, insulin, statins, and other weight loss drugs, and there is no prospective RCT currently exists for this endpoint. Now, the most contested safety signal is in the NAION category. There are certain studies by Hathaway et al., Simonson et al., and Grossland et al., which have shown that there is a very high risk of NAION in these patients. Whereas certain studies like Chow et al. And FDA Marrow et al. Have found that that risk is not significant. So there is another study where it is shown to be a rare side effect. Now, why this thing is very contradictory? Because NAI1 is a very rare disease and it's impossible to have RCTs in such rare disease because the sample size will be very low and the real world data remains the primary imperfect evidence source. Now, where the disease evidence is most consistent in IIH and glaucoma, this GLP1 receptor agonists have shown clearest protective signal in the literature. In IIH, choroidal plexus express the GLP1 receptors, and murine models have shown direct intracranial pressure reduction. Similarly, in glaucoma, topical or systemic liraglutide and other drugs have rescued up to 100% of retinal ganglion cells in hypertensive glaucoma models. In dry eye disease also, there is evidence that it might be protective. This GLP1 receptor agonist may be protective to the ocular surface. What could be the probable mechanisms? Because lacrimal gland tissue expresses the GLP1 receptors. The topical liraglutide induced inflammation and fibrosis, increased tear production, and was seen in a type 1 diabetic mouse model. Now, the open question is whether it is going to improve the meibomian gland function. That is again under question. There are different studies which have shown that because of the use of these drugs, there is a lower odds of getting the dry eye disease. Now, there are these GLP1 receptor agonists are not just single drug. The most common ones, semaglutide and all, are very popular, but there are many other drugs which come, and all the drugs have been into several studies, and they are giving conflicting reports. Now, one more important thing is perioperative consideration when you are doing a general anesthesia. Even if you are taking the patient for eye surgery, if you are doing, you have to remember that these patients have delayed gastric emptying, and they have a raised aspiration risk under anesthesia. So this is very important whenever a diabetic patient who needs ophthalmic surgery under GA. Now, what is the guidelines which they have given is most patients should not stop their GLP1 receptor agonist before anesthesia, and the high risk patients should follow a liquid diet 24 hours pre-op, and uh, no individual GLP1 receptor agonist is currently classified as higher or lower risk than another. Optimal timing for post-op resumption remains to be under study. Now, what we know and what we still don't know. Reasonably, we are confident that it protects against glaucoma progression, protects against IIH and intracranial pressure. It has a protective action against dry eye disease, and the class is genuinely heterogeneous. Individual agents will differ. Though the resolving, it's not still yet resolved how the effect is on the diabetic retinopathy progression status and whether wet AMD risk is real or is because of the confounding factors. True magnitude of NOION risk and in whom the risk is more, that is still has to be resolved. Optimal perioperative timing post surgery also has to be resolved. Now, why is the evidence very hard to pin down? Because most of these studies are retrospective electronic health records or database analysis and not randomized control trials. Heavy reliance on the ICD-10 coding accuracy for diagnosis is very important, and ophthalmology endpoints are secondary in most cardiovascular trials. The confounders like BMI, HbA1c inconsistently matched across Thank you for your patient listening. What topics would you like to hear from us? Please let us know. Also share your feedback. Thank you very much.